I'm Dr. Carey. I'm a pediatrician in Ventura, California, and we are talking baby care. Today I'd like to introduce Dr. Vaidya. Dr. Vaidya is an otolaryngologist, or in terms most of us can understand, ear, nose, and throat physician with West Coast Ear, Nose, and Throat. He's here to discuss babies who have tongue tie. Welcome. Boy, we have otolaryngologists, we have ankyloglossia instead of tongue tie. It's enough terms to make anyone dizzy. I always laugh whenever I go to a party and someone says, "Oh, what do you do for a living?" And I say, "I'm a pediatrician." And then they look at me and they don't quite know what to say, and then they stare, and the next they talk about their grandmother's kidney problems or something, and you try to sort of nod and say, okay, as if I know what's going on with their kidneys. But let's try to get back to some simpler terms. So we'll talk about tongue tie today. What is tongue tie exactly?
So tongue tie, well, it's great to be here. Thank you. Tongue tie simply is a tether of the tongue. So during development, before birth, the tongue is naturally tethered to the bottom of the mouth. And during development, that slowly releases. There's a little tether that holds our tongue to the muscle, and in some people that tether is either tight or short or attached too far forward. And so that is a tongue tie, effectively.
And then when a child has tongue tie, how do you determine? I know there are many classification systems. One of the classification systems we used to talk about was simply whether a child can stick their tongue past their lip or not, but it's become a little more complicated than that.
It has been, to some degree. So there are now multiple classifications that look at both function and look at the anatomy itself. The classification systems look at how far the tongue can protrude. They also look at how wide the tongue goes, how far the tip itself can move left or right to the roof of the mouth. They also look at the actual tongue tie, where its attachment is, how much of the free portion of the tongue there is, versus, so the location of the tether, and then they measure that. Some classifications measure that, plus the actual length of the tether itself. So it goes on and on.
For babies who, oftentimes, this is brought to the attention of the pediatrician because babies are having difficulty feeding because of this. For babies who are having difficulty feeding, are there certain types of tongue tie that tend to lead to more of a problem, or can any of them lead to feeding issues?
Right. So maybe if I can for just a minute, the big issue is that some kids have tongue ties, some kids don't. The incidence is reported all over the place, anywhere from as low as 2% up to as high as 10 or 12%. Most people agree it's somewhere around 4 or 5% in the middle, right? But nobody really agrees. Then the question is, what impact does it have? In general, unless it's, I would say there's fairly good agreement that the severity of the tongue tie, and however you want to define severity in terms of the anatomy, has some correlation to speech, in the sense that if the tongue is tethered to the bottom of the mouth, there's going to be a speech problem.
You do that well.
But there are many grades in between where people can accommodate for speech pretty well. Mm-hmm. The other side of it is the nursing. So when babies wish to nurse, the severity of the anatomic classification doesn't at all seem to correlate with the improvement that the baby will get after a procedure to release the tongue tie. Mm-hmm. And part of that has to also do with, there's two aspects of nursing. One is the baby, weight gain, how the baby is doing in terms of health, and then the mother, the pain for the mother and the difficulty that the mother may have, pain, infection, thrush, yeast infection, things like that. So there's two aspects of it. And there's many situations where the baby might be gaining weight, but the mother's having such a terrible time nursing that they are thinking they want to give it up because of the pain.
So how exactly is the pain related to tongue tie? I mean, if a mom has thrush, that has nothing to do specifically with being tongue-tied.
True, although some of the studies indicate that, so kids that have tongue tie have a difficult time latching. That's really the biggest issue. So if kids have a difficult time latching, it inherently creates pain for the mom. There's breakdown of the skin barrier, and that often leads to the thrush because of the milk that's in the area, the sugar, and so just the breakdown of the skin can lead to the thrush.
At what age is it apparent, and at this point, I'm not going to talk about the speech issue right at this moment.
Yep.
Let's talk about the feeding.
Right.
At what age is it clear, how many days old or weeks old is it clear that tongue tie may be a possibility? Because I see many moms who come in having trouble breastfeeding, and they're very frustrated, and it's 48 hours, milk isn't in.
Right.
We really haven't given this a chance to do their things. It's very, I mean, children lose 7–8% of their weight during the
Right.
first week of life. They're back at birth weight by 2 weeks of life. Milk does not produce right away. The baby latches on, a signal sent to the brain says, hey, make milk. Goes to the breast, starts making milk, and milk finally comes in a few days later. But many moms get frustrated in that interim. They're tired, they just went through having a baby.
Right.
They may have other children at home, and they want instant. So how do we know, when do we start to think that maybe tongue tie is the issue?
So that's also somewhat a little bit all over the board. The trend, I will tell you, is it's going more and more towards earlier and earlier, for the simple fact that the procedure is a very low risk procedure. And so it's one of those situations where the mom looks at it, they're having trouble, like you said, they're very frustrated. Is there something that you can do? And so they come and say, well, can you do something? Now, the reality is somewhere in between. We don't know if releasing it that early is necessary, helpful. Certainly by a week or 10 days, if the mom's having trouble, or if the baby's having trouble, it's reasonable. But I do get more and more referrals for kids that are newborns that 24 hours, 48 hours. And if it's a significant tether anatomically, then I will often go ahead and release those. If it's not a significant tether, I'll often say, well, why don't you come back in a week, 10 days, let's see how much better you're doing. And that's part of the classification system issue as well. If it's a significant tether and we think it may impact issues other than nursing later in life, then I think it's reasonable to release it. There's a good chance they're going to need it anyway.
Now, oh, go ahead.
And then just to finish the thought, if it's anatomically not a significant issue, and the purely only reason that we're doing it is to release it for helping nursing, and I don't see much of a tongue tie, what's now called a posterior tongue tie, I might tell them, why don't you try a week? But to some degree, it depends on what the parents' interests are, and we have to help guide them also, whether it's right or not. And it's an emotional decision for them many times.
It certainly can be, but also with the natural progression, when it's not when this procedure is not performed, the frenulum has a tendency to move back over time as it is. Do we really know that these that we call significant tongue ties, when we're looking at them, aren't going to resolve themselves, or at least not be an issue with feeding?
You know, the standard teaching has always been just that they do regress, they soften, they stretch, and that was certainly my training. But as I've seen kids older, because I see older kids also, and I check them and I ask parents, and then the newer studies really don't show that the tongue anatomy changes that much.
In what way? So we don't get regression of the frenulum over time?
Generally, it's felt that there's not much regression, maybe a little, and there is theoretically some stretching of that frenulum, but in general, it's not felt to do anything significant.
And for those in which tongue-tied hasn't been addressed, to what extent can it become a speech issue down the road?
So speech itself, the tongue is a remarkable organ. It can compensate quite a bit, and the rest of your mouth can compensate pretty well. So I've seen people that have what many would consider a significant, or a moderate, let's say, moderate to significant tongue tie, and they've compensated for their speech very well. So I think it's unpredictable. It's not that everybody with a severe anatomic tether will have a severe speech problem, but there's a much higher chance, I think, because they have a harder time compensating.
Do you end up getting adults then who come in with this as an issue because they hadn't had this taken care of as a child?
I do. It's not often, but I do probably once every other year see an adult that has a tether that has trouble either with speech or, if not speech, other activities such as licking an ice cream cone, trying to get their
lips. It's not going to work well, is it?
Yeah, trying to get their lips around their tongue around their lips. And it ends up being painful because the frenulum gets stuck in the teeth.
So what happens with these people when it's corrected as an adult?
So if the problem is anything other than speech, it improves pretty rapidly.
Okay.
Speech itself, for most of them, it improves fairly quickly, meaning a month or 6 weeks. Occasionally I've had somebody, it may take 6 months for them to readapt to the extra mobility in the tongue to help their articulation.
Do they need speech therapy at that point?
I've not had anybody that went to speech therapy.
Really?
Yeah.
So it just, you correct it as an adult, and the speech pattern that they've had difficulty with for umpteen years takes care of itself within a few months?
Slowly, over a few months.
Okay.
Yeah.
Fascinating. Are there multiple procedures that are done, or is it basically one procedure?
So there are two broad categories of procedures.
Okay, and we're going to have to make it brief because we only have a moment.
Sure. So one is effectively you snip it. The second one is you snip it and then you put stitches in.
Okay.
In general, you don't need the one with the stitches. Pretty much for all babies, I do it in the office, either no anesthesia or a little bit of local anesthesia. We snip it and then they do well.
And your complication rate has been?
Essentially, I have had no complications. From what we've tracked, there's been no complications.
Interesting.
Specifically meaning after the expected bleeding from the procedure, which is very minimal, there's been no bleeding, swelling, extended pain.
There's a lot to discuss with this topic, but clearly we don't have the time in such a short span to cover everything. I appreciate you coming over here. I thank Dr. Vaidya for joining me in discussing this perplexing problem. I am Dr. Carey, and I thank you for watching. For more baby care education and to sign up for our free newsletter, please visit us at drcareys.com. And remember, at Dr. Carey's, we teach baby care.
Breathe in, breathe out. Breathe in, breathe out. Okay. Let me see your ear.